Hi, everyone. My name is Michael Stewart. I am the Director of Education here at the OI Foundation, and I want to welcome everyone to this evening's OI and Bone Health Clinic Town Hall meeting. We're going to get started in just a minute or two, but I just want to remind everyone, like all other OIF meetings, we're going to be recording this session and posting it online to the OI Foundation's YouTube channel afterwards. And we can also email out that recording when it is available. If you have any questions during any of the many sessions and talks today, we ask that you please type in those questions into the Zoom chat. That way we can answer them during the designated Q&A periods. We want this to be as interactive as possible, so we really do welcome your questions. And then the other thing I wanted to bring up is that we're going to be having a evaluation survey, I know, coming up a little bit later, and we're going to ask everyone to please complete that. This is how we get in touch with you and we know who you are, and also helps us improve programs for the future. So please do give that a look later. So with that being said, I want to introduce today's the meeting chair for today, Dr. Laura Tosi. Dr. Tosi, hello.
Thanks so much, Michael, and thank you everyone for being here. Dinner time, end of the day. We never have a perfect time to meet, but it's grand to have you. As hopefully everyone on the call knows, we initiated these meetings a couple of years ago. It was in response to recognizing that whereas for decades, just a few places indicated that they were caring for individuals with OI. The fact is, we now have over 50 locations on our website. OI is a very complex disorder. Many people think of it just as brittle bones, but everyone on the call knows it ain't just brittle bones. And how do we all keep up to date? How do we know about what everyone is doing? We came up with this plan to have these town hall meetings, and we hope you'll continue to come and be with us twice a year as we pull everyone in and welcome them. So I am particularly excited to introduce our first speaker. Ayers works in the Cincinnati Children's Hospital Center for Excellence in Developmental Disabilities. She is constantly on the run and constantly speaking, and I believe she is sitting in the building where she's going to give her next speech an hour from now. So we are particularly honored to have her with us. The topic that we came up with for tonight is a topic that I am facing quite regularly now as my kids are getting older, so to speak, my kids. And are off to college. Many of the young people don't want anyone to know that they have OI. And that has gotten some of them into some pretty serious scrapes. So I am thrilled to have an expert start to open that topic up, and hopefully it'll be helpful to everyone. Kara, thank you so much. Mental health in youth adults with OI, the challenge of disclosure.
Thank you so much, Dr. Tosi. I am excited to talk about this. Specifically, drawing out this piece of disclosure was an interesting challenge and opportunity, I think, to kind of figure out where that fits in mental health. And it's a challenge that also, I think, is somewhat of a new one for us as we've had advancements in medical treatment. There are many people with OI, even in moderate form, that it may not be as visible. Myself, I have type 5 OI. I use a wheelchair. So in many ways, my wheelchair discloses for me. Disclosure means telling someone about your disability, but it doesn't necessarily tell what type of disability I have. And so I have also had to navigate these decisions in terms of when, how, and who do I tell in different settings. But I wanted to start with framing it in how does this fit into mental health so that hopefully you could apply this in your work with patients. So we'll talk about how it factors into mental health specific to OI. I also want to mention how disclosure relates to disability identity, and how disability identity, there's research that supports that it can actually be a protective factor against anxiety and depression. So this is me, if you saw me in the room. I'm trained as a clinical psychologist. I am at the Cincinnati, you said, which happens to be at Cincinnati Children's Hospital, which I love because I get to be a part of all the not all the happenings, that would be a lot, but many of the happenings at the hospital. But you have UCEDs in every single one of your states and territories if you're here in the United States. So please use them as a resource for things like this. Sometimes they have workshops specifically about disclosure. They also have, a number of workshops on transition. It goes down the list, but use your UCEDs if you aren't already. And I don't have any disclosures for this talk, which I realized was somewhat confusing considering it's on disclosures. So this first slide is just noting that in 2019, there was a systematic review done that summarized 13 studies about the impact of OI on families from a psychosocial perspective. If you want to check this study out, you can point your phone at this QR code and it should give you a link, and these slides will be available afterwards too. I'll make sure to drop a link in the chat box if you don't get it right now, but you can read that review, and I'm also going to tell you some key themes just so we're on the same page. Some takeaways that I found interesting but not all that surprising were that stereotypes about the euphoric nature of OI and just the endless positivity may be toxic, and maybe, of course, unintentionally applying pressure to our patients and to people with OI in their uncertainty about whether it's okay to be sad, depressed, anxious, afraid. That kind of breaks the mold of the unbreakable spirit in some ways. So those overall stereotypes, without making sure that there's some gray in between those black and white areas, may be harmful. We also saw that there were high rates of anxiety, but unfortunately low rates of social support. So I see that as an opportunity to build support however we can. So when we're thinking about young adults, especially after they leave school settings, it can become much more isolating and more difficult to figure out where one fits and where one can get that social support they need. And then really just OI, unfortunately, from a mental health perspective, can be a bit of a perfect storm, as I discuss more in this next slide, because it's this combination of things. So the cumulative effect, pain, fear, isolation, uncertainty, and reduced function, when we throw that in the mix, can also upheave even pretty solid mental health. So specific to anxiety, which I think is what many of us hear from many people with OI in the community, also adding to this perfect storm is a heightened sense of body awareness, which can actually be really great for many things related to OI, being aware of one's pain and what that pain feels like. Is it muscle? Is it bone? But when you are also hyper aware of your body, you tend to pick up on other bodily sensations as well, like our heartbeat speeding up, or getting a cold chill, or all the different ways that our body can feel changes in anxiety. And sometimes we can misinterpret those signals too. So there are some psychosocial interactions happening that contribute to the anxiety experience as well. Also, I wanted to mention medical trauma. It is nearly impossible to escape childhood with OI without having medical trauma. And that's even if you're fortunate enough to have everyone in your life trying to reduce that trauma for you. It is, largely a reality of existence and life with OI. So recognizing that and treating it as such and normalizing it is an important way that we can respond to that. There's also trauma in ableism and exclusion, and that's really the type of trauma that we often forget about. We think only about the bodily aspects or the negative aspects, even socially, of OI, but ableism has a real role in this, and I'm going to share that next. First, I did think it was important. I know Ingunn is going to describe much more detail about pain, but specific to the role of pain in mental health and what we're discussing, the difference between acute and chronic pain, and kind of when I listen to young adults and also adults talk about that gradual movement into an experience of chronic pain and what that is like for people, it often involves a great deal of stigma. So there can be self-doubt, wondering, I'm being lazy. I'm not trying hard enough, because pain, can also often be expressed in a lack of stamina, fatigue. So there's that self-doubt, but there can also be what is perceived or is very real doubt from medical providers, especially, and I think all of us know this on the call, but if fractures are used as the primary verification of a real legitimate injury or issue. So pain is important in this discussion, not only of mental health, but in disclosure, because pain is very hard for our general public to understand. I can tell you that I work in the not only the healthcare space, but even more specifically the disability space, and probably getting my close colleagues to understand pain just enough for me to have them understand some needs that I have is probably the most difficult part of my disclosure, because I think it's a compassionate response that when you disclose pain, people want to help and they want to take things off your plate and they don't want you to worry about it because you're in pain. And for many of us, including me, it's much more complicated than that. I don't want you to take away my leadership responsibilities or assume that I can't do something because I'm in pain. I just need you to know that it's part of my experience. And so I may be approaching things a little different. I might be remote that day. I may need to work some different hours. And sometimes it just comes down to as simple as like, I'm rubbing my leg and people are like, are you okay? What's wrong? So it's this double-edged sword when you disclose. When you let the cat out of the bag, per se, you can't put it back. And you can continue to educate people, but sometimes you can't help the way their mind runs away with OI either. So I've definitely encountered that, as have many people, in terms of deciding what is like too dangerous for me once they know what I have, what disability I have specifically. So I use this image all the time in like full-length talks about ableism. It's an image of a smog coming out of a smokestack. And to me, it illustrates how ableism, which are these messages that disability is bad, are in the air all the time. And we can't escape them. And we're breathing them in, whether we have a disability or not, but including those of us that have a disability. So we really have to actively work against those messages. And that's another challenge in maintaining mental health with OI, optimal mental health, and also figuring out disclosure, because when you tell somebody about your disability, they already have an idea about disability, and many times their ideas are largely negative and not accurate. And honestly, those are sometimes the ideas that people with disabilities themselves have about themselves. We definitely encounter that when young people with OI aren't connected to many other people with disabilities, and they can form some pretty negative ideas about themselves. So ableism definitely gets in the way of our ability to disclose disability without just putting it out there, which is what I wish we all could do. One of the challenges is that it's not a one-time thing. We have to disclose over and over, multiple places, multiple times, multiple people. So it's really a good idea to practice almost a script, and that script changes. I think in a pediatric setting, many of us have heard like the cute and also effective, like one-liners that kids have that explain OI. Maybe it's as simple as, my bones break easily. But those one-liners expand to what you're going to use in the workplace setting, in college settings, also in friendship and dating settings. These are other places that you need to disclose. And, our current world, I think, makes this even more interesting and challenging when you think about online dating, where you can really build quite a relationship with someone before they may see you, or definitely before they know your genetic history related to OI. So that multiple needs to disclose is a challenging piece of this. Helping to coach someone how, when, and to who they disclose matters. So if your patients or people with OI you're working with are considering whether to disclose to housing for their university, it's always helpful to go to the person that can help route that information. When students come to me and they're thinking about if they want to disclose and how on things like medical school applications, which happens to me at least a handful of times every year, various medical disciplines. People want to go to graduate school and training in that, and they want to know how and should I disclose OI or my disability. And that's a much more gray answer for me. I think that in some cases, training programs can be trusted to have that information and still make a fair selection process. Other times, students decide to go through the selection process and then once matched or selected, try to work out the accommodations they need. It's not ideal, but also there are a number of experiences, including my own in psychology internship matching, where one year I disclosed, one year I didn't. The year that I did not, I received double the number of interviews. So I can't in good faith tell people, oh yeah, put it out there. But I do tell them to disclose as soon as they can after they get matched. So disclosures can be hard, but it also opens us up to a number of accommodations and supports that we need. And it's better to do it proactively. So I wanted to conclude with just a couple of strategies too that I think you could integrate. Reframing the barriers that people with OI face can also be very beneficial to mental health. So taking it out of the individual when it's actually a system or a structural problem. So in this case, she can't get into that building because she's in a wheelchair is actually very different than she can't get into that building because it's not accessible. So removing kind of the blame of exclusion and segregation, not that we mean it as blame, we never do, but even in that first way that it's described, our language is suggesting that the reason she can't get in that building is because of her and how she gets around in her wheelchair. When, in the US at least, we're 32 years after the ADA, so the reason she can't get in that building is at least also because it's not accessible. Another thing I want you to keep in mind, and I go into more detail on this on a podcast that's on the OIF website that I know we can find the link for if you need it, but I talk in more depth about disability identity, and there's increasing research that shows that disability identity matters to mental health. It decreases anxiety and depression. And specifically, I cited a study by Kathleen Bogart. I work with her on a number of research endeavors, but this study found evidence that predicted lower anxiety and depression and multiple sclerosis. And then she's built on that with a number of other studies. Keeping in mind that disability identity affirms disability rather than denies it. So it doesn't mean that you necessarily are to the point where you're having pride in your disability or you're thinking that it's all great or even mostly great. It's simply that you're integrating it into who you are and you're affirming it. And for you, that might mean you play adapted sports or you have friends that also have disabilities among your friend group, but it simply means affirmation, and disclosure is affirmation. It's affirmation to others, so it's challenging in that way, but it is affirmation. So providers can support disability identity formation by acknowledging ableism, that you recognize that's a part of this experience, acknowledging pain, mental health challenges, social complexities. And then on the parent, family member, friend side, they can support disability identity by learning to be an ally. Providers can too, but I think there's a lot of overlap in that. And this last slide, I believe it's my last one. Oh, I'm going to leave this one up for just a second. So these are different ways you can contact me. And then this last QR code is my Google Scholar profile if you want to check out other work. So thank you. I think I have a couple minutes for questions. Oh, thanks, Erica. You found my podcast.
Thank you. That was terrific.
Thanks.
I'm how do I help my kids have that identity, disability identity? That isn't a concept that I've really faced or heard about before. I love the data. And as I'm looking at my kiddos, particularly going off to college, being a little bit unsteady, so to speak, on their feet, a little unsure of themselves. How does one introduce that idea? and expand on that idea for the kids?
I think for many people, if they've had the chance to be in community with other people with OI, which I know we've had a gap in that in the last few years in person, but that can spark it for a lot of people. I find sometimes teenagers and young adults may be resistant to that at first if they've never done it. But sometimes when you get them in those spaces, it's sparked. Also, I mean, that there are more opportunities to not be as isolated with your disability than there were before in terms of social media places that young adults spend time. There are now, influencers that have disabilities and OI. I mean, it's fun to, I'm thinking of Kristen Victoria. It's fun to follow her like world travels as, somebody with OI that uses a wheelchair. And so I think exposure to other adults with OI, whether it be via media or even better in person, is one way to start helping young adults be able to see a future for themselves and figure out what that identity looks like for them. It doesn't have to look, like the adults they're in contact with, like any part of our identity. I think
Sure.
they'll build it in their own way.
Terrific. And just as a small, how shall I say, advertisement,
Yeah.
please note that on the web that our team has put a link to her podcast on disability identity and OI, which may be helpful both to you and to your staff to be aware and have access to that. That's important. And anyone with additional questions?
I have one question. It's Tracy Hart from the OIF. Kara, that conversation that a young person would have with their family about disclosure, how important is that? Because, other people may disclose for you. And, how do you start that conversation, or, somebody that wants to help you start that conversation?
Yeah, I think that's a great point, and I forgot to bring that up, so I'm so glad that you are. I think it's really important for families and young adults with OI to talk about like what's okay to disclose and what's not. I mean, as my kids are 5, 12, and 15, and my 15-year-old is the one with disabilities, and my 5-year-old could care less if I told the world everything she did, but I am learning that my 15-year-old wants less out there, and it's so important to respect that so that they can build their own identities. Also, unfortunately, sometimes when you give people more, they can misunderstand that or use it in ways you didn't expect. I think maybe a slight intervention too that I might use if I were a provider and having quick conversations around this discussion is asking people, what's the worst that can happen if you disclose? And now sometimes the answer is actually pretty bad. Like, well, I won't be matched to this really important internship site that I want because they'll know that I have OI and they'll be worried that's a liability. But often when you really hone in on what's the worst that can happen, it comes back to that question of like, well, I'm just nervous to tell that to people. But if you're looking at the flip side of the coin, like, well, but you'll get a first floor dorm room, which will really set you up for success. And, so it's that give and take between accommodations and what you need and putting a part of yourself out there. But starting with the family and knowing what's okay and what's not, and really bringing the provider into that, because sometimes providers need to write letters and you as a provider need to know what to put in that letter. And I know you all are pretty good about not being too detailed anyways, but that could be important depending on what you're disclosing about too.
Thank you.
Yes.
Thank you tremendously, Kara. That was just great.
Yeah. Thank you all.
All righty. So now enjoy your next presentation.
I will. Thank you.
We're so grateful. Take care. Our next speaker is a dear old friend, Dr. Paul Esposito, a long-term leader at Children's Omaha, and he's going to bring us up to date, so to speak, intramedullary nailing in OI, where we've been, where we are, and where we need to be, is important to me because I sure remember when I couldn't get my hospital to buy any form of nail. and I was having to beg, borrow, and steal. So at least my hospital now thinks they need to have a set. That's a good step forward. But Paul, bring us up to date. Welcome, welcome.
Well, thank you, Lauren. And seeing the surgeons that are on this thing, it's a little bit sobering because I've had the joy of sharing learning with each of them. And to go back what you and Tracy were talking about, 20 years ago, we weren't together. We weren't speaking the same language. And now I don't see as many kids from Alabama because Mike Conklin's down there doing a great job. And Laura and Dr. Flanagan and Georgia, we have people all about now, and we all talk the same language. That came to roost when we were in Sheffield, where I thought I was giving my last talk until Dr. Tosi asked me to give this again. So to Dr. Wallace and Dr. Franzone, I apologize, but it was just a great time. But you know, what have we learned, and why do I have more questions now than I did 20 years ago? And I think that's an important thing. But the ability to talk to each other, I think, is the key to this. So Dr. Fossier was obviously the one that started much of this, although it was built on things that came before us. But the multidisciplinary team has been really consistent, and it still is, to me, the mothers who tell us what the kids need, and then the patients themselves so they get to be teenagers. And Dr. Tosi's had a big part in us listening to them and asking the questions. And it's got to be consistent worldwide. And I was impressed when we were in Sheffield that although some of the nails and things are a little bit different, the concepts are all the same. And as always, the principles never change. And that's the last so-filled procedure I ever did. I used to take us 2 units of blood, 4 to 5 hours, and a spica cast for 3 months for one bone. We've obviously moved far along from that, but we had a huge impact. And for those of you who are not surgeons, I don't want to make this into a surgical thing because the surgeons know at least as much as I do, if not more. But intramedullary nailing has its place in improving function. So we always assess the functional need. What is it the patient wants? Discuss the options. I mean, it may be that, you know, the classic for me was the mother who told me that her child needed his humerus fixed when I kept insisting on those 90-degree bowed femurs need fixed until she said, well, he can't sit up. So I think we've all learned by listening to our patients and their families, what do they need? And, you know, we owe it to them to work together to determine what can be done safely and have the greatest impact. So to me, the clear-cut indication of recurrent fractures and pain, which is pretty much everybody we run into to some extent. But the surgeries we've been doing have had a dramatic change in comfort and medication needs. And although I don't think we've taken away all the pain and all the trauma that Dr. Ayers was referring to, we certainly made it different. It's also important, I think, to address psychomotor function. That early 18-month-old who can't sit, can't crawl, they're really losing a lot and getting way behind. So we want to fix it when they really need it. We want to fix it the day before it spontaneously fractures. And we know, and it hasn't changed since Dr. Fossier taught me this, that if they're pulling up to stand and they've got 30 degrees of bowing in their femur, they're going to break their leg. And it's rare to have a child that's too small to put a telescoping nail in. But to be honest with the family and say, the younger we do this, the quicker we're going to have to revise it. And there is a role for slim nails and flexible nails, depending on where you are in the world and what you have available. Rigid rods are bad. The stress riser at the rod always causes a significant deformity, and you don't put them in where we normally would. The entrance point is always medial to the trochanter, not to the tip of the trochanter. And avoid plates and screws whenever possible. We use locking plates now, but we do that in conjunction with a small intramedullary nail. The stress points at the end of the plates every time will go and fail. And the first law of orthopedics, or one of the first laws, is thou shalt not varus. It's especially true on femurs and people with OI. They always fail if you leave them in varus. So if you use flexible nails, it's okay early on, but it's especially important to protect the bone end to end, avoid stress risers. And the tip of the trochanter and then is the entrance point or medial to it. Backing out is more of an issue with OI. All the nails that I've seen around the world lock on either end, and that's to try and prevent migration. Some centers spike a cast for short periods of time. We haven't done that, for better for worse. I think one of the questions we have to answer at some point is this matter in terms of rotational control. Are we creating a deformity, or is that just part of OI? If you look at all the kids with type 3 and type 4, they all externally rotate, and that's how they sit, and that's how we get them. So I'm not sure, short of doing an osteotomy with an intermedullary nail and a locking plate, you can control rotation. But we use a post-op brace. We're doing multiple surgeries. This is an expense, and you can't do it everywhere, but we have the luxury of doing that in the States. And we learned an awful lot about post-op pain. 20 years ago, I was managing my own pain, or my patient's pain, did a terrible job. Pure narcotics just don't work. The kids don't like being on narcotics. I'm very proud of the fact that very few, if any, of our kids now that are not young adults are taking narcotics on a regular basis. I've not seen that studied, but I can tell Dr. Tosi and I suspect know a lot of young adults that were addicted to narcotics with OI prior to the onset of this type of medical and surgical treatment. And Valium, we just use on a regular basis. That's not a PRN medication the first 2 days post-op. That's an around-the-clock medication. And my colleague here from anesthesia taught me an incredible amount. And Jess has just been a wonderful leader. And I'm sure we're going to learn more about pain in the next talk. But I'm a real big believer in epidurals. We've done hundreds without complications. They don't always work, like any technique, but when they do, they're marvelous. And what about protrusio? We don't have an answer for protrusio. And this is a young lady who was actually a gymnast or cheerleader who just kept banging, 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 and got that fracture. Doing CT 3D reconstructions is interesting because you can see in most of these kids where there's an infolding of the pelvis. It's different than Marfan's, and it's different than other diseases. But we don't know what the long-term implications of this are. And can we actually fix it surgically? So I think that's a real big question we're going to have to answer. And what's the effect of reproductive abilities later on in life even, and pain. So the rates of non-unions seem to be the same before and after bisphosphonate treatments. So I think the argument about do you give them bisphosphonates immediately post-op, do you hold it 6 months, has been answered because it just doesn't seem to make a difference. And if the patient needs it, we give it. We don't give it the week before because that can cause increased bleeding. But we do give it immediately post-op when they have IV access, because I think you have to take into account what is the access ability in these kids and how much of a hassle is it for them to take another couple of days off to do that. And why do some kids get non-unions even if you do everything perfectly and you do the perfect surgery but not other? And how in the world does someone with type 5 get a non-union? Dr. Wallace has several of these patients, and for the life of me, I can't figure that out. You think they would heal like gangbusters. Femoral non-unions are a big deal too, and we tend to use a lot of cortical allografts, and that's been a real blessing. Two things that happen when you have the disappearing bone disease: one, they don't have any bone to fixate to, and using an allograft, either with cerclage or screws or plate, cortical allograft really is helpful. One of the biggest causes of non-unions in femurs, in my experience, has been putting the nail in too far lateral. People are worried about AVN, and it just rarely happens, if at all. I think Peter Smith in Chicago has one case, but that's out of thousands and thousands of people. And the cortical allograft really may disappear over time, but at least in the short term, until you put a smaller rod in and get the load sharing back in place, adds a lot of cortical thickness. And again, why some disappear and why some stay, I don't know. What about tibial non-unions? Again, like varus in the femur, you can't have any residual anterior bone in the tibia, or you will predictably get an anterior non-union. We put them into a little bit of hyperextension to try and avoid that now. The kids don't seem to be bothered by it in the least. It really cuts down on the amount of migration of the nail. It allows you to put the nail more posterior. If the nail is anterior to the midpoint of the tibia after you're done with an osteotomy, it's going to migrate. It's just very, very predictable. So when we do get a non-union, we've been doing an awful lot of small locking plates in conjunction with grafting. The X-ray here on the left is a patient of Dr. Paul Sponseller, who's written a nice paper on using screws and allograft rather than cerclage. We just like to use cerclage for the plating in conjunction with it, because that's what works better. But the questions we have are, is there some other structural or biological issue that we're missing when it comes to these non-unions? Well, how about the upper extremity? Because I've learned the most there, and I think when I first started doing this, we rarely did the upper extremity. Now we do it all the time. The mother that told me, my child can't function because they can't prop themselves up and tripod sit, told me that we have to look at that. So basically we ask them what's bothering you the most before we do it. And quite honestly, the humeral fractures are as painful as femur fractures in my experience. So those are big things to take into consideration. You can fix a lot of deformity with limited soft tissue disruption in the humerus. The caveat to that is be very careful in the distal third, because obviously the radial nerve won't take a joke. So you have to visualize that when you are doing osteotomies. But in the upper part of the humerus, you can clearly do percutaneous osteotomies, or even closed osteoclasis. The non-union rate in the distal humerus is much higher because there's 3 planes of motion. There's valgus varus, rotation, flexion, and extension. And if you look at this one here, it also shows you what the humerus is not an isolated bone. You can see the radial head's dislocated on that lateral. And that's something we've looked at more and more closely as we've taken care of more kids and they've gotten older. So here's a non-union, one of the first ones we saw, and Dr. Fossier told me they're horrible, they don't heal. He was right. I did several revisions of this in grafting. And this, I believe, is the first patient where locking plates were used in conjunction with rotting in humerus. We put these things in with grafting. It healed. We had to revise the humeral nail. Obviously, there's a lot of Rube Goldberg we do. We don't have the ideal instruments to fix everything, but if you use all the tools in your toolbox, you can get an 18 or 13-year follow-up and somebody who's very, very functional and doing well. So he's now 15 years post-op, and again, his arm's fine. But what about forearm fractures? We ignored those the first 4 or 5 years that I've been involved in this because we were kind of scared of them. They're some of the wildest deformities I've ever seen. And at least the very creative surgical approaches. And both Dr. Franzone and Dr. Wallace have had those experiences with us, where at the end, you're not exactly sure where you were, but you knew you got there safely and got out of there in time. But probably the biggest impact of all the things we do are these osteotomies in kids. I'll tell you that the both bone forearms where both bones are bowed, you can probably sit on and wait a while longer because they're not going to dislocate the radial head. But if you have just the ulnar bone, even if it looks just very subtle to begin with, it's going to go out further and further lateral. And these are the kids that come back when they're 15 and say, oh, my elbow hurts now. What can you do? And we say, we can't. So I think we need to look very closely at those with isolated ulnar deformities because it's a Montegia equivalent. I think we need to realign and fix the ulna much more frequently than we do now, and not hesitate to do so if it's a functional problem. But again, resecting the radial head later on in life is much harder. You have to really ask yourself when both bones are bowed, is this important to this individual now? Can we wait a while? It does take a great deal of segmental resection in many of these deformities, but the arm always looks more normal in length, and the family will remark on how much longer it looks. Smooth wires can always back out, but now that we've been tamping them in a little better, that doesn't seem much of an issue. And surprisingly, even if the forearm's been male rotated, the interosseous membrane closed for several years, they usually get their motion back. We try and put them in a functional position just in case. And many deformities are plastic. We can just take and bend them and they'll correct, and sometimes even do them percutaneously without doing any open osteotomies, but not always. And again, the ulna is easier to control and correct percutaneously many times. And the radial entry point has to be right through the tip of the radiostyloid, and we bury that in. We actually developed a special tamp with a concave surface, basically like a finishing punch and for finishing nails, and rarely do they back out now. But it obviously has the limitation of non-growing nails. But surprisingly, even when the nails grow, frequently the kids get their bones stronger and they don't develop progressive deformity again. So this is a 13-year-old girl with recurrent fractures non-union. This is a case that my colleagues from the DuPont Institute were kind enough to give. There are ways to use the slim nail like this and get fixation proximally. I do worry a little bit when the kids are prone to olecranon fractures using this, and what's going to happen to at least a growing child when you're putting that big threaded portion into the olecranon apophysis. But I think that's another thing that just has to be seen, because it is a great tool to use. And angular deformity, we've worked a lot with using 8 plates and guided growth. It works great. It's a whole lot easier than fixing and doing major osteotomies. Retrograde nailing was hot with our Italian and French colleagues in Europe. I think there is a role for it here. This is a child that had antegrade nailing, had been in there for many years, outgrew it, got a distal osteotomy. We were able to slide the slim nail in proximally. And so retrograde technique has the ability to help you in some very specific instances. The issue of doing an antegrade nail in somebody with that much coxa vara, that much protrusio, it's very difficult to get at that. So having this in your toolbox is obviously a very important thing to do. And then femoral neck fractures. This again is from Rich Cruz and Dr. Franzone, combining the antegrade technique with a percutaneous screw. I'm very wary about leaving femoral neck fractures with just the screw and failing in the lateral cortex, but that hasn't happened to this point. So varus corrected and the retrograde nailing. And I'm going to buzz through here because and coxa vara is something that's correctable. Again, medial to the trochanter, overcorrect the neck as much as you can. And in summary, the early realignment almost always allows improved mobility. Early surgery may require revision as the kids outgrow the rods quickly, and we hopefully will get better ways of developing techniques to get better mileage out of our rods. But distal fixation of tibia is not as secure in the femur, and that's another big issue that needs to be worked out. Is there a better distal tibial fixation? Increased activity leads to more revisions, but increased activity, in my mind, is a wonderful thing. And non-union rates are comparable to previous studies prior to bisphosphonates. And we need longer follow-up to tell what is going to happen to the adults. And I've been keeping tabs on many of my kids as they go off to college. And as Dr. Ayers said, there's more challenges as you go forward. But the biggest thing is we're working together. We're speaking the same language, and we're going to get better. And I think it's been amazing to have the support of the OI Foundation and our colleagues to share knowledge and develop things around the world. So thank you.
That was spectacular. Thank you very much. I think that nothing I do has changed as much as my orthopedic care of the OI patient. And you captured so much of it so very quickly. Do we have any questions at this point for Paul? Michael, help me. Did we show our slide about the conference for next week? 2 weeks?
We have not yet.
Okay. So while we have potentially some folks with orthopedic interest, is it possible to just flip that up for a moment right now? I'm undoing Michael. But I think that one of the things that COVID taught us is how much we can share. So Paul gave us a great, unbelievable tour through the last couple of decades of my life. But revision, always a challenge, is a topic we barely touched on. And I'm tickled to tell you that there will be a presentation on that in 2 weeks and through the Care for Bones site. And I hope that you will have an opportunity to participate in that as well. Thank you, Michael. And we'll put that in the chat for those who are interested. Now, the next presentation was pre-recorded. I hope everyone knows Ingunn Westerheim. She leads the OI Federation of Europe. And they have extensive participation by adults. And they're just as Kara spoke to, the issue of pain management, et cetera, is a leading topic. And particularly in our older patients, I would argue, who didn't have the advantage of bisphosphonates and rotting. The theme of I have PTSD comes up all the time. And they've really stepped up, and we just want everyone to be aware of their study. We apologize. There's a little trouble with hearing. And so I would ask you to be sure to turn up your volume so you don't miss her introduction to what they're doing with pain and OI in Europe. All set, Michael?
Mhm.
Hello, everyone. My name is Ingunn Westerheim, and I'm the president of Osteogenesis Imperfecta Federation Europe. And today I'm here to tell you about our collaboration project with the OI Foundation called the Pain and OI Project. First, a little bit about OIF, which is an umbrella organization in Europe for organizations that deal with OI. We have 20 organizations in Europe, and at the moment we have 15 national OI organizations who are associate members or partners around the world. In addition, we have 4 supporting members. Our most important activities at the moment include the PAIN project, future events, which includes a topical meeting in Stockholm, the impact survey and access to future treatments, and we are also pretty involved in patient engagement in research and development, and also regulatory affairs in Europe. As you can see from this slide, we represent our members in many different European forums and conferences. So, to the point, the problem, pain. It's reported to be the most important challenge for people with OI besides fractures. And wherever you search, there is hardly any solutions for this problem. How do you deal with pain management? What is the best medication? What are alternatives way to deal with pain? So this is why we all started to think, what can we do about this? This is the background of the project. And as you can see, more than 60% of people with OI have chronic pain, and the percentage and complexity increases with age. All of us, of course, deal with acute pain in addition if we have fractures or soft tissue injuries. In spite of this, as I mentioned, there is very little information about how you can manage pain as a child or adult with OI. There is also little knowledge and awareness about different kinds of pain in OI among people with OI themselves and professionals. So together with the OI Foundation, we established an international expert group, or resource group as we now call it, because it's difficult to gather people from all over the world in workshops. So it's a resource group including 27 participants from 11 different countries, Europe, Canada, US, and Australia. It's covering both pediatric and adult professionals. It's a very multidisciplinary group, which includes physios, orthopedic surgeons, endocrinologists, rheumatologists, anesthesiologists, pain specialists, psychologists, pediatricians, researchers, nurses, and a social worker. We also included 3 people who have OI themselves. And in addition, we are 3 OIF people and also some people from the OIF who contribute with different perspectives and also help with the administration. So why do we say that more than 60% of people with OI have chronic pain? Did we get this from just looking at Facebook or social media? No. There are several studies now confirming that pain is a big problem for people with OI. A very recent article that comes from the multi-center study, the BBDC, says that among 861 individuals with OI, 41.8% had chronic pain, which was most frequently located in the back. Predictors of chronic pain included age, use of a wheelchair, and numbers of fractures per year. It also covered what kind of treatments were used, and the results from the study showed that chronic pain is prevalent in OI across all types, affects mobility, and interferes with participations. The findings are very similar from other studies. This is very hot data. It hasn't been published before, but the impact survey, which included 2,278 respondents, and this was 1,442 adults, found that more than 80% of people with OI have issues with pain. There's also a recent PhD study, and an article is published in English by Ruben Munoz from Spain. You can see him in this photo here, together with the Spanish team who is working for the Spanish OI organization, AHUSA. He found that in a cross-sectional study that in 418 adults with OI, that pain was reported frequently up to 83% of the population in the study. The biggest country in this study were the US and Spain. So this is also a very nice figure from study done by Alison Boyce and her colleagues, illustrating that pain in OI is multifactorial and it's in many different areas of the body. It's the brown dot here that is illustrating pain in OI. So what have this group done? Well, we have had 4 workshops so far. We have agreed on 4 common goals, recommendations on how to assess pain in OI, including different kinds of pain, recommendations on how to measure pain in OI in the clinic and in clinical trials, educational activities about OI and pain to various target groups, and a toolbox on management of chronic pain for children and adults with OI. Our ambition is not to come up with clinical guidelines or a big consensus document, because we think it's very hard to give recommendations that will be valid across all countries. So our aim is to make a toolbox that the people with OI can bring to their local providers and discuss pain management with them. We're also planning a survey organized by the OI Foundation and the OIF to gather more information from the people with OI about knowledge gaps. And in addition, OIF and the OIF are involved in another industry-sponsored project related to OI and pain, which will probably include a literature search and qualitative interviews of people with OI from 5 countries. So we have discussed different challenges, and one of the challenges is how to measure pain. So this is a nice example that both combines the basis but also descriptions, because many people with OI find this scale to be a bit challenging. When you live with pain all the time, how do you put a number on it when you are seen in the ER, or when it comes to chronic pain, it's even more complicated. So one of the participants in the group is Professor Audun Stubhaug from Norway, who is leading one of the bigger pain clinics in the Nordic countries. And his view is that pain scales are more or less useless in chronic pain. The main thing is to find out how the pain is preventing the person of functioning. So pain interference is the key. Does pain interfere with your social life, work, sleep, etc.? Problem is, however, that the EMA and the FDA and other regulators always require us to include pain intensity to measure efficacy of a drug treatment. So pain scales are necessary in clinical trials, but perhaps not so useful in the clinic. This is also a screenshot from one of our workshops about which pain assessment tools that can be relevant in OI. Our discussion concluded that there is no perfect questionnaire. Doesn't exist one tool that fits all, and definitely different tools for different ages. And it's a different objective if you're doing research or you want to evaluate clinical response. We should strive to use validated tools, multidimensional tools, and to be consistent in pain evaluation. So our goal is to present some results at the topical meeting Balancing Life with OI, which will take place in Stockholm from June 9th to 10th, not the 8th to 11th, June 9th to 10th in Stockholm, Sweden. And pain will be one of the main topics, and how pain interferes with sleep, mobility, family, and relationships. So, final questions. So these are some of the questions we are discussing in the group. How does pain in OI differ from pain in other conditions? What is the connection between OI, pain, and hypermobility, sleep, fatigue?
I think we lost our sound.
I think we did.
With OI.
Luckily, the questions are written out.
There she is.
My apologies. I'm going to rewind a few seconds.
Will ICD-11 provide a better classification system for chronic pain? What is the connection between pain and physical function? What coping strategies are most beneficial when it comes to pain and OI? Do people with OI ignore or cope with their pain for too long? And are there any other factors that can help buffer mental health problems because of pain? This could be peer support, parental support, coping, resilience, etc. So this was a big, quick overview of the pain project. You will probably hear more about it in the future, I hope. I say thank you for the attention. If you have questions, I'm unfortunately not a night owl anymore, so you would have to email me or ask Tracy and Erica to answer your questions. Thank you very much.
We were very excited that she was willing to do that for us. Again, pain is such an important dimension in OI. And as part of our town hall, we want to be sure that you are up to date, not just on things that are going on here in the United States, but internationally. And certainly, I would love to be in Stockholm in June, but that's a whole different issue. So miraculously, we're right on time for our agenda. And it's very exciting for me to present our next speaker. So many, it's so funny because I don't think we really thought our patients were going to live into adulthood when we all started in this business. But boy, do we have lots of adults these days with lots of new and different questions for us. So Deb Krakow is going to give us our women's health update. I think everyone knows Dr. Krakow, but just to remind you, she is professor and chair of the Department of Obstetrics and Gynecology at UCLA. She's also a professor of orthopedic surgery and human genetics. I don't know how she does it all. And I won't use up her time by carrying on, but I'll say thanks so much for being here. Welcome. But you may be on mute.
All right, can you hear me? Laura, somebody wave at me. if you can
Yes,
hear
we
me.
can. Thank
Okay,
you so much.
wonderful. Well, I want to
Huge
thank
thanks for being.
the OIF and Dr. Tosi and all my colleagues for the opportunity to do a small update on women's health. Oh, let's see if I can get this. So I think that all of you have heard me talk about this before, but when I think about women's health, it really is across a lifespan. There's fetal, pre-puberty, puberty, reproductive, and menopause. And for today, I'd like to sort of focus on the reproductive pregnancy issues, which I've spoken before. And I'd like to talk about menopause because I think we're shoveling up a big boulder up the hill. Women have unique health issues relative to men. They include pregnancy, menopause, and obviously the female genital tract is different than the male genital tract. There are some health issues that affect both men and women, but they can affect women differently. Women are more likely to die during a heart attack than men. Women are more likely to show signs of depression and anxiety than men. And it was interesting to think about that in terms of the last talk and pain. The effects of sexually transmitted diseases can be more serious in women. Osteoarthritis affects more women than men, and women are more likely to have both acute and chronic urinary tract problems. Other issues that I think are interesting and I think we need to address within our community that may be unrelated to bone is alcohol usage. Men are more likely than women to become dependent on alcohol, but the health effects are more serious in women. This includes an increased risk for breast cancer and heart disease. And human and animal studies have demonstrated that chronic heavy alcohol consumption compromises bone health, increases the risk of osteoporosis, and decreases bone density. This is in the average stature non-OI population, and it's something that we've never, I don't think, as a group explored in our community. And I'm open to whether or not this is something that we should be talking about. The effect of moderate alcohol use on bones is less clear. And as a practicing physician, I will tell you that for patients, the definition of heavy and moderate is quite personal. So I'm going to just do a very brief review on pregnancy in women with OI. And for those of you who know me well, we've been studying this for a long time. Dr. Rao, who started this as a genetics fellow, did a survey through the longitudinal study as well as through the OIF, where we looked at pregnant women who responded based on a total of about 220 pregnancies. And we compared the responses from women with OI to published normative data in the general population. And there were things that were obviously somewhat not surprising, which included that women with OI in pregnancy had shorter stature and a lower BMI. They had a statistically increased cesarean section rate. There was an increased use of in vitro fertilization relative to the general population. There was an increased signal for gestational diabetes, and I quite honestly can't wrap my head around that and why. There was an increased need for transfusion. There was increased fractures in both the antepartum and postpartum period. There was an increased incidence of lower birth weight infants that were unrelated to whether or not the infant had osteogenesis imperfecta or not. And there were higher rates of NICU admissions in neonatal mortality that was unrelated to osteogenesis imperfecta. So I want to go on to a question that I am asked constantly, which is whether or not breastfeeding is good or bad for women with OI. And I think in the general population, the benefits of breastfeeding are clearly established. The American Academy of Pediatrics, I mean, we joke around, I think would like to have children breastfed till they're 10 years old. They keep increasing the age of what they advocate for. And this was particularly important during COVID, where access to formula, as we all know, was compromised. Unlike pregnancy, most of the calcium obtained for breast milk is mobilized from bone, and estimates of decrease in DEXA scores after breastfeeding approach 5% in the first 5 months, and women at least of average stature, non-OI women, are thought to recover. There are controversies about whether or not high parity, which means having a lot of children, is associated with osteoporosis, but the studies are not large. Overall, the few studies that I could find included women with up to 4 pregnancies, and it does not suggest that being pregnant often is associated long-term with an increased risk of osteoporosis. Fractures are known to increase in the postpartum period for our patients with OI, or at least in the study that we did. And, you know, one of the things that I think we have to talk about is if you have a form of OI with rhizomelia or significant mesomelia, or you're short-trunked, it could be technically just difficult to breastfeed. And at the same time, society places an enormous sort of pressure on women to breastfeed as long as they can. So our study showed that there was an increased incidence of fractures in the postpartum, antepartum, and postpartum period, but we did not correlate it to whether or not women breastfed. There was a recently published paper in 2022 where they looked at 50 women who were pregnant with OI from 10 bone centers in France, and they saw an increased incidence similarly to us of fractures. The most frequent locations for the fractures were the femur, the spine, and the pelvis. Fractures occurred in the 3rd trimester or in the postpartum period, which are correlated to what we found in our study. And breastfeeding was reported in a large percentage of the fracture-verse group versus individuals who did not breastfeed, and they seem to have statistically less incidence of breastfeeding. They also reported that, you know, the bone mineral density was significantly lower in women who had pregnancy-related fractures compared to other patients. This was not done while breastfeeding, it was just in general. And they made the recommendation of women with OI should aim for optimal, you know, osteoporosis risk factors. And they said that breastfeeding should be avoided, which, you know, again, I hopefully you can open up and have this for discussion. However, there was a published paper soon after that where they did a 2-month observational group of 111 women with a total of 205 pregnancies. And they followed them and they calculated fracture rates for those women 12 months prior to pregnancy and then 12 months after delivery. And they felt they could not identify any increased risk of fractures when comparing fractures prior to pregnancy or postpartum. So their conclusion was that pregnancy and breastfeeding was not necessarily adverse to bone in osteogenesis imperfecta. So I had the opportunity, and I'm pleading with all of you, if you know any pregnant women with OI, to follow one of my patients who I had seen, as you can see, in 2017, 18, and 19, and between 2019 and her delivery in July of 2022, she underwent in vitro fertilization and then had a term pregnancy. And if you look overall at the numbers where the values are starred in her spine, left hip, femoral neck, and total body. So the last DEXA was done 6 weeks after delivery, you can see there was at least an approximately 5% decrease in some areas, which correlates to what we see in the normal population or unaffected population. And she is continuing to breastfeed, so we're going to be able to follow her. She has an interesting history in that she has mild OI due to haploinsufficiency for COL1A1, and her mother had vertebral fractures after both of her deliveries. So, you know, this is a study that we're really trying to get off the ground to really try to answer this question. I'm not saying people should or shouldn't breastfeed, but I think it's an important question, and whether or not women with OI recover their bone mass when there's cessation of breastfeeding. So I'd like to move on to menopause. Menopause is defined as a cessation of a person's menstrual cycle. It is defined retrospectively, so it's 12 months after the final menstrual period. Perimenopause is a menopause transition. It's a few year time period. And essentially what's going on is that your menstrual cycle lengthens. There's more periods of having no period, and you begin to develop symptoms such as hot flashes and sleep disturbances. At the same time, the prevalence and incidence of chronic diseases, cardiovascular, cancer, osteoporosis, and generalized fractures are increasing with age. And so there's an intersection between chronic disease and menopause. The reason why this is important, because, you know, people are now expected to live on average more than 30 years after menopause. So this was just published about 2 weeks ago, and it was by the U.S. Preventative Service Task Force, where they looked at the use of combining estrogen and progesterone for the primary prevention of chronic conditions in the postmenopausal women with and without a uterus. And they concluded with what they said moderate certainty that the use of estrogen alone for the primary prevention of chronic conditions in postmenopausal women had no effect, and the combined use had no effect either. So they concluded that the use of estrogen and progesterone postmenopausally will not have a profound effect, if any, on chronic conditions. I have to note that their evidence was grade D, which means that a conclusion is neither possible or there was extremely limited information to make. So I think that this is published in JAMA, but I think it needs to be like questioned perhaps. They looked at 5 trials of using estrogen and progesterone. And I want to draw your attention to the following. They found that there was a lower risk of fractures in people taking estrogen alone when compared to placebo. And actually it persisted 4.3 years post-intervention follow-up. And there was, so I think that the question is they don't acknowledge it strongly, but there are decreased fractures in women who are taking estrogen alone. They also commented that hormone therapy is approved by the U.S. Food and Drug Administration for the prevention of osteoporosis and does reduce fractures in the postmenopausal women. But they go on to conclude that given the overall benefits and harm of hormone therapy, they don't believe the prevention of osteoporosis using hormones is of a net benefit at the population level. The North American Menopause Society recommends that hormone therapy should not be prescribed for chronic disease prevention, and they agree with that, but that it does potentially be helpful for women for the prevention of osteoporosis if alternative therapies are not tolerated. So they kind of hedge a little bit. And I think both societies, both the task force and the Menopause Society, recognize the benefit of hormones for bone health. So I just want to conclude, because I hope this opens up a conversation, but we are going forward on a new survey in OI and pregnancy, and we are going to focus on two things: postpartum hemorrhage and fractures. And what we've been able to do is we've been able to hopefully engage a company that will collect all the medical records on people who do respond to the survey, so we can actually get more concrete data. Most of the data that we have is really survey driven, and it's based on people's recollection, which I think is very, very good, but it would be helpful to be able to document it. We are also working on trying to identify individuals who are pregnant with OI, who we can actually follow post-delivery at 6 weeks and then at the cessation of breastfeeding. So if anyone has pregnant patients, I'm begging you, please contact us, and we would love to work with you. So thank you.
Terrific job as always. Thank you so much. All righty. And do we have any questions? Don't see anything in the chat yet. So Deb, I think the hard thing, and I'm a pediatric orthopod, but I'm certainly very sensitive to fractures. I think the hard thing is there isn't anything wonderful to tell our OI women. We're really in trouble there. You know, even in women who don't have OI, there's talk about, well, should you give them bisphosphonates for a year or two so they don't have that menopausal loss? At this moment in time, based on the data you have, what are you telling your OI women as they enter menopause?
So I think it's a great question, and I think that's really important for those of us on the line and people in the in our community to really read these studies, because if you read through the lines, they do say hormone replacement has a benefit on bone, even in non-OI patients in the general population. And it's as if they're saying, well, okay, well, it doesn't affect cardiovascular health and dementia and other chronic diseases, and so the whole thing on bone, big deal, right? So they kind of blow it off and say, well, given the other serious conditions and there's no benefit, the benefit of hormone therapy may not weigh the risk, the increased risk. However, in our community, for particularly women with milder forms of OI type 1, or haploinsufficiency, you know, not having them lose bone mass and fracture, it may be a real benefit. Now, of course, you know, we have to talk about breast cancer and all the other things, but I think what I'm concerned about is that our women are going to go, they're going to go to their gynecologist, they're going to go to the internist, and people are going to say, well, this was just published in JAMA, we're not giving anyone hormones. And I'm not sure that that is absolutely the right thing for us. I mean, we have a unique population with a unique constellation of concerns and issues. And I'm open to debate. I don't know if any of you are interested, but I found this great survey from the Survey on Menopause in the North American Menopause Society that I think we should send out to our women who've gone through menopause and see what they're saying. But I think there's not a lot of options to preserve bone mass, and we know that estrogen absolutely does. And the box.
And I have been very impressed by how a fracture in anyone, but particularly adult OI women, can take away their confidence and their balance. So it's a very difficult choice. We have a question, and Carolyn, I'm going to clobber your last name, from Carolyn Machika. Is genetic counseling readily available to women with OI considering pregnancy? And is this done in concert with their OBGYN?
I think it's a great question. And the answer is, at least my patients who do, and obviously this is a longstanding patient and she had IVF for a reason that was for her personal. So we offer it to all our patients with OI to say, we will follow you in your pregnancy and care for you. And if this is something that, is important to you, we will provide you whatever resources, whatever expertise we have.
I do think that some of our young people sort of want to have children, but don't always want to have children with OI and take that risk. Are you walking them through the options of how they could affect their risk?
Yeah, I mean, I think we really try. We talk about what's technically available, right? You can have in vitro fertilization, you can invasively test the pregnancy on a DNA basis and make a decision, and we just try to listen to what the patient feels their quality of life is and what they want. And, as we saw in the survey data, this was 200 and over 200 pregnancies from all across the country. People are using reproductive technologies to, I'm assuming, not pass on their genetic change. So I wouldn't say everyone in the community of taking care of people who on both sides who just say whatever. And I'm completely supportive. So I am not getting on a soapbox about eliminating alleles. I just want people to understand that it's what technology is available, and people get, people hopefully are comfortable in their own skin, but they should make their own reproductive decisions.
You're here. Great. All righty. So, Deb, thank you so much for joining us. That was just great. And again, everyone, do help out. I think recruiting patients for a study such as Dr. Krakow is undertaking is incredibly difficult. And I hope we can all be supportive. That's for sure. So next on our agenda, Tracy Hart is going to talk to us about some of the clinical trials that are going on to support our community. Deb,
Sure.
huge thanks.
Thank you so much, Dr. Tosi, and thanks so much to Dr. Krakow and Dr. Esposito, Dr. Ayers and Ingunn for wonderful presentations tonight. This has been great. I'm not going to take much time at all. I want to direct you when you get a moment to our website, and I know we're going to put in the chat the link to our research page. Listed there are ongoing and open trials. So some of them are through the Brittle Bone Disorders Consortium. So you can look there to see what studies are going on. But I wanted to just quickly give you sort of a perspective from the OI Foundation, how we engage with industry, with pharmaceutical companies on their clinical trials. So we are always open to partnering and getting the message out to our community about ongoing clinical trials. We want choices, we want treatments, we want, more research being done. So right now we have shared information. You might have seen information, and some of you, many of you are actually sites for some of these, or one of these trials anyway. So we work with Ultragenics on the Orbit study right now, which is open to people from 5 to 26 years of age. I think those are the parameters, pretty sure. And what we do here at the OIF, and what we've done with Ultragenics from the beginning, is we've worked with them and Mereo Biopharma before that to help insert the patient voice into their protocol development. So we've provided them with patient advisory panels and boards, and they can we can give them information about what's realistic for our community to participate in a trial. So we really want to be there early. We want the patient voice to be right there at the beginning of any trial. So you'll see information from us, from the OI Foundation, about the Ultragenics study. You will also always see at the bottom a disclaimer that we're not endorsing, we're not recommending, we're giving you the information. We want you to contact the sites to decide if this is right for you, if this is in your family. The other study is a Sanofi study. It's called POISE 1. It is a phase 1 study, early phase study. So, and they are looking for adults with OI type 1 and 4. Again, you can look on our website, and it's in the chat. There's a link to that study as well. And again, we're doing the same thing. We're providing them with patient advisory panels, and we are, giving them advice on what things are reasonable for a patient community to participate in a clinical trial. So I just wanted to give you that update so you can share that. And like I said, some of you are already sites for at least one of these studies. So thank you, Dr. Tosi, for letting me update.
Thanks to you, Tracy. That was great. Appreciate it. So just to remind, we have our survey in the chat. We are ever so hopeful that you will fill it out. Trying to connect over 50 clinics across the country is a tough job. And we want to be sure that we are providing the information and the opportunities that you are looking for. That's for sure. And hopefully you'll do it. You don't need to look at me. I'm the last speaker. So you can be doing the survey while I just chat for a few more minutes. And then we'll actually be able to give you back a little of your evening. Always a good thing. That's for sure. So I'm just going to give you a brief update on some of our PCORI work, Patient-Centered Outcomes Research Institute. I'm excited to report we're now on our 4th award. And this one is particularly dear to my heart, so to speak, in that we are looking to improve transition of care for our young adults and access and quality of care for our more senior adults. Our award is one in which we are seeking to speak to large numbers of folks, both from the community and their caregivers, but also to you as clinicians from our various sites to find out what you're doing, what your challenges are, etc. I have to be blunt. It's so interesting. At the beginning of COVID, boy, we could get people to do anything all the time. Everyone was sitting home, and now everyone's so wonderfully busy. But the fact of the matter is that translates into us having a little bit of trouble recruiting patients and caregivers. We haven't actually started to call you guys up yet, but we will soon. If you are caring for young adults, their caregivers, or senior adults, we would be very grateful if you would encourage them to participate in our studies. Our goal is to get everyone's opinion and as diverse a set of opinions as we possibly can, so that we can help the OI board, OI Foundation board, develop a roadmap. In Health Affairs last month, there was an incredibly important article that really underscores what happens to so many of our patients. The title is, I'm not the doctor, I'm not the right doctor for you. And I think this is an incredibly important issue, that it is so hard to help our adult patients find care anywhere, much less high quality care. I'm not sure what we can do to help, but I do think we need to make every effort to try, but we really need to know what the lived experience is, what your patients and parents have discovered, patients and caregivers, and certainly what you're experiencing in your own communities. So Michael put his email, always easy, mstewart@oif.org in the chat. If you're willing to to work with us, we would be very, very grateful. And with that, we're technically done, but we're eager to have you unmute and join us if you have questions or something you want to speak up about. That's for sure. So welcome and do speak up. But don't leave without doing our survey. That's for sure. I think everyone needs their dinner. Thank you so much for joining us tonight. Really enjoyed it. Hey, Matt.
Thank you.
Great evening. Thank you.
Thank you. Good night.
Take care.